the following point. This is the disclaimer, of course, as usual, and we'll try to cover the disease burden, and then we'll discuss the updates. And this is the most important because all of us as oncologists and medical community aware about the role of immunotherapy, and we were discussing this issue for the last years, but nowadays we have updates. So, and this is the most important, that we have to be, updated year by year for the benefit of the drug which we use in our practice. So we'll update the keynote 024. This is 5 years. And I will go concentrate on the first line. Then we'll go to the disease that means squamous and like by the two important trials which are, or we can say, vaccine and hormone trials, and animal trials, and for 5 years or 5 and the keynote 189 again, 5 years or 5. Then we will try to delete the benefits of the one and our talk with the consideration of the perspective, which is very hot topic in value of cancer care, value-based cancer care, which we are almost all aware about the course of it. And I think this is one of the questions that will be asked from many audience in this regard. And as usual, we will conclude by the NCCN guidelines. So let's start with the disease burden, and we know that lung cancer, based on the global and report 2020, is almost constituted the second top cancer in the incidence. And we can see that can be the breast cancer. And when it comes to the mortality, which is the most hard to control, we can see that lung cancer is the killer number one among cancers. So this is we are dealing with important and serious problem that we have to treat this condition. And we look at the local data, we can see that from the latest report of the cancer intelligence that cancer incidence among the population comes among the top 10 cancers in Kingdom. Comes after breast, colorectal, thyroid, conjunctival pneumonia, and conjunctival lung cancer. This is among the overall the six. While when it comes to the males, it shows up in the top cancer in males, and constitutes about 5.1%, with annual incidence around 349 cases, while it is not prevalent among the females, among the top 10 cancers in females. And we can see that the lung cancer, we are lucky because of lower incidence of and prevalence of smoking. Among the population, this comparison with the other cancers or the worldwide increase, it is almost, has very low incidence of the lung cancer. So what about the incidence by region? You can see that because of the high prevalence of smoking in the East region, the East region comes first, or the highest incidence rate in Georgia, Makkah. And Iran comes almost sixth position. And we can see that most of the cases, and this is a bad news, that almost 65% of the cases, they come with metastasis, and which is a little bit worrisome, and they are this group is the target of our patient market. basic data about immune therapy. We know that immune therapy mainly work on the PD-1 and PD-L1 pathway, and the role of the immune therapy is to release the brake from the T lymphocyte. So the best tumors that respond to the immunotherapy, those hot tumors. So we need hot tumor to respond, and we can see the magic response that we see in aggressive lung cancers and the breast triple negative breast cancer. All of us as oncologists, we see the amazing response to the addition of pembrolizumab in the neoadjuvant and triple negative breast cancer, because those tumors are hot tumors. So we need high invasion of the T lymphocyte in the tumor in order to benefit from the releasing of the brakes of the tumor by the effect of the immune therapy. And we know that the most important in dealing with the lung cancer, that we have to look for any actionable mutation before consideration for any immune therapy. And for that, we do now comprehensive gene testing, which is, we are lucky enough in most of the countries now, it is a free of charge available test. We call it the next generation sequencing, to be done for all the comers, all the lung cancer patient, especially those with metastatic, to know if there is any actionable molecular driver. And we can see that those patients who are non-smokers, when they develop cancer and usually adenocarcinoma, this group of patients, usually we may find the actionable mutation. So never smoker, non-small cell lung cancer have a higher probability of having actionable molecular drivers. So this is important part to consider before you go and to consider immune therapy in lung cancer patient. Now, and we know that one rule we have to respect it, that we have one way, that means we should not use immune therapy before the targeted therapy. We should not rush to use immune therapy or prescribe immune therapy before looking for any actionable or targetable mutation, because this is the wrong pathway when we start with immune therapy. The proper pathway, it is one pathway starting with targeted therapy if there is actionable mutation, and we usually we either to use it as single agent, and most of the cases, despite of some data now about the combination with chemotherapy, and then we end up with the immune checkpoint, because it is not only the effect of less effect by using the immune therapy in the start, and immune therapy it is used for all. It is while the targeted will go to the action, the molecular so while the other that is also maybe detrimental to use the therapy after targeted therapy immediately. Now, we may start with this patient. I remember you were talking about cancer 2007 and 2006. Our colleagues were talking that the survival rate and the disease survival 24 months. And maybe 6 months with the treatment. Now, I had this patient came to us season for 2021. And this patient admitted in cardiology in our hospital. She's 50-year-old lady. And admitted with a case of pericardial delusion and pleural delusion. We can see that this patient has this initially pleural delusion, pericardial delusion, and so and with the patient that have the mass. So when the cardiologist saw this mass, immediately they told us that there is explanation for this pericardial delusion and pleural delusion. So how we approach these cases, as usual, we have to go for it, and we have to get gas as much as we can. So the first step is to look for the histology And our expectation for this non-smoker lady that she will end up as adenocarcinoma, and that was the story. So she was non-adeno non-small cell lung cancer, adenocarcinoma. But this is not enough to start the treatment patient. Now we have to know more details. What was the next step? That we have to send the samples for next generation sequencing. So NGS is important in this regard, and we did it. And we ended up that there is no actionable mutation. During the waiting time, we can start, as long as we have the histopathology, we can start chemotherapy. So the patient started as adenocarcinoma and carboplatin, and we sent for NGS. Then the discussion was, can we treat this patient with the immune therapy alone? Can we add immune therapy? Yes, we can add immune therapy as combination with the chemotherapy, but consideration of monotherapy will need testing, specific testing, which is PD-L1 testing. So PD-L1 testing was done for this patient, and it showed that it is almost 1%. So that means this patient is not eligible for monotherapy. The patient started on chemo immunotherapy as per Keynote 189. Now, the question coming from our colleagues that can we use immune therapy alone in metastatic non-small cell lung cancer? And the answer, all of us familiar with it, because it came from landmark trial, which is Keynote 024. And we have now the 5-year overall survival update of this trial. It is this is the trial, and this Keynote 024, we have to remember the name because this is landmark trial, and it tackled and checked the response of metastatic non-small cell lung cancer to monotherapy pembrolizumab monotherapy in comparison with platinum-based chemotherapy, and this was for those patients with PD-L1 TPS score, which is abbreviation TPS for tumor proportion score, 50% or more. And we have the data from the initial data, because now we are talking about 5 years follow-up for the trial, while we have already the data of the initial evaluation or the initial cut-off point analysis of the trial, which was done at 2 years, and it supported that the benefit of monotherapy is there. And the follow-up included not only those patients with PD-L1 more than 50%, but also the intention to treat population. And also they followed those patients who completed the 35 cycles of pembrolizumab, and those patients who received a second course of pembrolizumab after a discontinuation of the treatment. And the most important part that we have to know that Keynote 024, it included not only the adenocarcinoma, but we have also 18% of the patient were squamous etiology or squamous histology, and they also included those patients with treated brain metastasis, which usually excluded from many clinical trials. And it was international trial that include also population from the East Asian, which constitute about 13.6%. So, and we can see now the final evaluation or the result, which done after 5 years follow-up for this use of pembrolizumab, and we know that the treatment given for 2 years or 35 cycles, and the benefit was continuous as 5 years and more. We can see the nice separation of the curve, and we can see that the benefit, the green line is the pembrolizumab, while the brown is the other arm, which is the chemotherapy. We can see that pembrolizumab was much better than the chemotherapy, and it is almost showed doubling of the overall survival, 31% after 5 years. And the curve separation was maintained with hazard ratio is almost 0.62. That means there is 38% reduction in the risk of death among one of the challenging cancers, non-small cell lung cancer, which by both types, squamous and non-squamous. So by using only immunotherapy, pembrolizumab alone without chemotherapy. So we are now talking about chemo-free protocols. So the benefit of there, at 5 years and more, we have almost 32% of the patient alive. So we have overall survival, and also we have progression-free survival. Those patients who are alive, they are disease-free in around 23% of the cases, and we can see that the difference is the separation of the curve is very clear, and there is continuation of for the separation of the curve with the hazard ratio of 0.50%. That means there is 50% reduction of risk of death by use only of immune therapy, no chemotherapy. So we have now a long follow-up for this landmark trial, and the most important is the durability of the response. The durability of the response, it is almost 29, or we can say 30 months duration of the response in the pembro, while it was 6 months in the chemotherapy. And just of note that the patient received, I will go back to the curve. Just we can see that the benefit of pembrolizumab or the immunotherapy continued after the duration of the treatment, which was 2 years or 35 cycles. So this is the good thing about immunotherapy. It is not only the response, but the lucky people those patients who almost cross the 35 cycles or 2 years, usually those patients, they sustain the response. And when we select only those patients who completed the 35 cycles, that means 2 years of the pembrolizumab, we can see that the overall survival among this cohort reaching up to 81%. And among them, we have almost 10% complete response rate, 72% partial response, and only 3% progressed. So these are the lucky people, the lucky patient who maintain or sustain the response. So the good thing about immunotherapy, whenever you have a response, the response will continue. The success will continue. Now, if we stopped the treatment, what might happen? And we revisited the treatment again. So using of second course for pembrolizumab is an option. We can see that those patients who stopped the treatment and then they needed it because of some disease progression, we can see that there is again benefit there. And we can see the objective response rate 30%, which is lower than the initial response, but it is there. And we have a partial response rate reaching up to 33%. So this gave us a hint that we can revisit the immunotherapy after progression. The toxicity of the treatment is, and I think all of us as oncologists and the patient themselves, they are familiar with the treatment now, and they like it because we don't see any side effect. Even what we noted in the or what was mentioned in the trials, not reflected on our population. So I think we need some local data to compare the real world data with what had been published, that there is some grade 3 side effect or adverse event found in pembro 30%, 53% in the chemotherapy. But a real practice, the thing that we have to be aware about is the hypothyroidism by doing thyroid function. So the conclusion of monotherapy trial, this keynote 024, it clearly that after 5 years follow-up, we can see that Pembro alone continues to show this meaningful improvement in the overall survival and durable response versus chemotherapy. And we can see that those patients who completed the 2 years, they experienced the long-term overall survival. And the other also conclusion that we have from this trial, that second course Pembro at the time of disease progression was feasible and associated with the anti-tumor activity. And grade 3 to 5 adverse events were lower with Pembro. No safety signals we have. So this established the role of Pembro, a single agent, as an option, or maybe the preferred option as per guidelines for those patients with PD-L1 50% or more as monotherapy. And now there is expanded use of Pembro monotherapy, not only in lung cancer, it used also in lymphoma, also colorectal cancer, MSI high, bladder cancer, esophageal cancer, renal cell carcinoma, head and neck squamous cell, and also melanoma. Now, after using monotherapy, now those patients who have the PD-L1 percentage less than 50%, what to do for them? Do they have chance to use immune therapy? Yes. But in this case, we are using it as a combination. So we have the one trial for the squamous, and we'll start with it. Then we'll go to the adenocarcinoma. We'll start with the squamous. Now, for the squamous, the trial called 407. And now we have the overall survival update for 5 years of this trial. And this trial, just as a reminder, we can see that it used the pembrolizumab. In addition to that, they combined it with chemotherapy, carbotaxol, carbopaclitaxel, or carbo-nab-paclitaxel. And usually we use carbotaxol area under care of 6 every 3 weeks, paclitaxel 200 per meter square every 3 weeks, or nab-paclitaxel 100 weekly, 100 per meter square weekly. The most important that we have to remember that we are using chemotherapy only for 4 cycles. Then we continue the pembrolizumab for to complete up to 31 or 35 cycles maximum. Now, the other arm is the chemotherapy alone. So we can see now that this is the 5 years updates of this trial. Now, we can see nicely the separation of the curve. Now we are talking about squamous cell metastatic, those with PD-L1 less than 50%. So we can see that first note that we have early separation of the curves, which usually we know that immune therapy, it takes some time to show some benefit. But here we can see early separation of the curve. And we can see now after almost 5 years follow-up, we are talking about overall survival, and we are talking about the intention to treat population. That means for all the comers, regardless of the PD-L1 status. We can see that pembrolizumab showed almost 18, those patients who received pembrolizumab, 18.4% of them are surviving now, till now, yani 5 years, in comparison with 9.7% with those used chemotherapy alone. So the addition of 4 cycles only, it is 4 cycles chemotherapy, then they continued in pembrolizumab. They are enjoying disease overall survival almost 20% of the cases, with hazard ratio of 0.71. That means the drug, the combination, reduced the risk of death by 30%. Now, when we check just look to the table down the slide, that when we compare the TPS1, that means PD-L1 positivity more than 50% or less than that, we can see that the benefit is there, regardless of the PD-L1, despite that the higher the PD-L1, the lower the hazard ratio. But the benefit is found If it be BDL1 more than 50%, 23 months, 23% 5-year survival. If BDL1 from 1 to 20 to 49%, the overall survive 5 years, 20%. When it is less than 1%, the 10% of the patient, they survive it 5 years. So, and when it comes to the progression-free survival, we can see this is again in the all-comers intention to treat population. We can see that the early separation of the curve with the BFS at 5 years, it was 11% in the pembrolizumab use. So that means double of the chemotherapy, which was the chemotherapy only 3% who used the chemotherapy at 5 years survival. Now, the hazard ratio here is 0.62%. That means 38% reduction in risk of progression or death. Now, when we look to the PFS also regarding the BDL1 positivity, and usually the companion test for this pembrolizumab is TPS. So we can see that regardless of the level of the BDL1, the benefit is there. But again, the PFS also, the higher the PFS, the better the PF, the higher the BDL1 percentage, the higher the progression-free survival rate, 15%. And if the TPS more than 50%, 11.8 when the BDL1 from 1 to 49. And when it is less than 1%, the BDL1, it is almost 7%. They survive 5 years. They survive disease-free 5 years. Now, what about the response rate? We can see that the response rate also found in all the comers. And we can see that those patients with the TPS or the BDL1 more than 50%, they have almost double response rate to the by the use of pembro chemo in comparison with chemo alone. So while we can see the response in all and reaching up to 67%. And the duration of response is also found in all the comers, and it is almost comparable between the regardless of the BDL1 status. And again, the best responders or the best, achievers with better outcome, those patients who completed 35 cycles with pembro. So these patients are the lucky patients because, as we said, the more durable response, this will reflect on the sustainability of the response. Now, those patients who completed 35 cycles, they have response rate reaching up to 90%. And we can see that the benefit for this benefit was after discontinuation treatment. That means the overall survival 3 years after completion of the pembro. So now we have 5 years of the follow-up. 2 years with treatment with pembro. 3 years after the completion of the pembro. Total 5 years. When they involved those patients, they found that those patients who completed the 2 years of the treatment successfully, they survived 70%. They are almost alive. And 16% of them, they achieved complete response. And 74% they achieved partial response. And there is no safety signals among the groups, and this is reflecting our daily practice. And they concluded that now for the squamous cell carcinoma, 5-year follow-up for this combination of pembro plus chemo, that has maintained overall survival and progression-free survival in comparison with chemo, and regardless of the BDL1 expression, and sustained improvement were observed despite an effective crossover, despite the crossover between the two arms. But the benefit was there, and toxicity and manageable the toxicity was manageable, and the best responders, those patients who completed 35 cycles of Bimbro, and they experienced long-term overall survival. These data support Bimbro chemo as standard of care first-line option for metastatic squamous non-small cell lung cancer. Now we'll go to the adenocarcinoma, and this is the most frequent type of non-small cell lung cancer. We have the landmark trial, which called Keynote 189, all of us aware about. Now we are talking about the 5-year follow-up of this trial, and this is an important trial that changed our practice because it opened the way for all of our patients who have no actionable mutation with PD-L1 less than 50% to enter in this trial with adenocarcinoma. Now, what they used in this Keynote 189, they used Bimbro like what had been used in the Keynote 407, and the backbone of chemotherapy was pemetrexed, and this is the usual protocol which we use in adenocarcinoma, 500 milligram per meter square, combined with carboplatin area under care 5 or cisplatin 75 milligram per meter square, and we are using it for 4 cycles. But in the adenocarcinoma, we drop the platinum backbone or part, and we continue this Bimbro with pemetrexed. So we keep some chemotherapy in the adenocarcinoma. We don't, keep only pembrolizumab in this case. Now, so 4 cycles chemo, and then we'll continue the Bimbro pemetrexed, and usually we continue the treatment for 31 cycles or 2 years. So what is the outcome? We can see nicely that there is impressive separation of the curve, and it was early separation of the curves with the using of Bimbro plus chemotherapy reduces the risk of death by 40% with hazard ratio of 0.60. And we can see that after 5 years follow-up, we have almost 20% of lung adenocarcinoma metastatic surviving the cancer. And in comparison with the 11.3, that means we have twofold, double the percentage of the overall survival. And this is among the intention to treat population, that means the whole comers. Now, when it comes to the PD-L1 level and reflection of the PD-L1 level on the overall survival, we can see that the benefit was there regardless of the PD-L1 level. But when it comes to the those with more than 50% PD-L1, it was 29%. From 1 to 49, it was 20%, and it dropped to 10% when the PD-L1 by TPS less than 1%. Now, what about the progression-free survival? We can see nicely the separation of the curve, which was early separation of the curve, with the hazard ratio here is almost 50% in comparison between the by the addition of chemo, 4 cycles of chemo to Bimbro in comparison with chemo alone, and we can see that this will reflect on 50% reduction in the risk of progression or death, and the PFS was 7.5% in the Bimbro chemo arm in comparison with only 0.6% in the chemo alone arm. And the benefit was regardless of the PD-L1, but the higher the PD-L1, the better the benefit regarding the PFS. What about the response rate in lung adenocarcinoma by the use of Bimbro plus chemo in comparison with chemo alone? We can see that those with PD-L1 more than 50%, they have almost more than double the response, reaching up to 62% in comparison with 25%. But the benefit again found in all the comers, and the duration of response also is reaching up to 15 median 15 months, and the higher that the PD-L1, the better the response. Who are the beneficial patient from the addition of immune therapy? Those patients who completed 35 cycles of the treatment. And we can see the response rate reaching up to 86% for this group. And when they completed 5 years now follow-up, that means 3 years after completion of the 2 years of the treatment. Now, 3 years without treatment, without pembrolizumab. Now, after 5 years, 72% of the metastatic lung adenocarcinoma are surviving. They are alive without the treatment. So this is the good news, that we have almost the benefit there. And this group of patients then constitute about 14% of the patient on Pembro in the KEYNOTE-189. Now, there is again no safety signal, and we can see that as we practice in our daily practice, the main side effect is immune-mediated side effect related to the it is related to thyroid, which is hypothyroidism. While so they ended up with this conclusion that with 5-year follow-up, Pemetrexed platinum maintained overall survival PFS in patient who treated for non-squamous non-small cell cancer, regardless of PD-L1 expression. And the benefit also observed despite of the crossover that was allowed. And usually this crossover usually, decreased the percentage of survivors or the benefit of the drug. But here we can see that the benefit was there even with this large number percentage of the crossover. And we can see that there is no safety signals, and the best responders were those who completed 2 years of Pembro. They usually experienced durable response, and 72% were alive after 3 years. And these results continue to support the combination of the first line Pembro, Pemetrexed, platinum as a standard of care in patients with metastatic non-squamous non-small cell lung cancer without actionable mutation. Now, what about analysis of those patients with weak PD-L1, less than 1%? So they joined, or they analyzed in joint fashion those patients, concentrated mainly on those patients with weak PD-L1, less than 1%, based on the TPS testing, tumor proportion score. And this joint analysis for the KEYNOTE-189 and the KEYNOTE-407, those for adeno and squamous. We can see that the patient, this analysis included almost 43% with squamous, and included also high risk group with liver metastasis, which in 13.7% of the cases. We can see that the benefit is clear despite of the low percentage or low expression of the PD-L1, which was less than 1%. The pembrolizumab showed almost 12.5% 5-year survival in comparison with 9.3. That means 1.5% for benefit, or 1.5 fold of the response. Now, when it comes to the hazard ratio of the use of the drug or the immunotherapy in those patients with PD-L1 less than 1%, it was 6.64, reflected on 36% reduction in the risk of death. So the benefit of there, despite that it is lower than what we saw in the intention to treat population when the PD-L1 more than 1% was there. Now, the progression-free survival also is there with hazard ratio of 0.66%, and there is also a difference 4.6 versus 3.7%. When it comes to progression-free survival, to that mean after the second line therapy, from randomization to second line therapy, we can see also the benefit was maintained, and the hazard ratio was 0.55%, and there is still separation of the curve. Now, the response rate is still maintained. It was 50% among those patients who are supposed to be weak expressors of the PD-L1 less than 1%. And the duration of response was 7.6 months in comparison with 5.5 for without immunotherapy. Adverse events are comparable, the grade 3 to 5, despite I think that this percentage is not reflecting our practice. Now, again, those patients who completed 35 cycles, despite that they were low, and that we are talking about the low expressors of the PD-L1, we can see that the benefit was there, and response rate was 92%. And after completion of the 5 years of the treatment, 56% of them is still alive as per follow-up. Now, this conclude that again, even in those patients with less than 1% PD-L1, the 5-year follow-up and this joint analysis of the 2 trials showed durable improvement in overall survival and progression-free survival, overall response rate, and PFS2. And those patients who completed 35 cycles, that means 2 years of the treatment, they experienced durable response, and 57% of them were alive after 5 years. That means after 3 years from completion of the treatment. And so these results continue to support Pembro plus chemo as standard of care first line for metastatic non-small cell lung cancer with PD-L1 TPS less than 1%. Now, I think some will ask me tonight about the cost of the effectiveness of the drug and in comparison with the other options. Now, there is a cost analysis done in Saudi Arabia, and it showed that they compared the 2 available options, despite that the other option, which is Nivo-AP, is not, the AP part of it is not formulary in Saudi Arabia. But when they compared we can see, we'll start with the left side bar histogram here, that we can see that the cost of the treatment of non-squamous patient we start with that means adenocarcinoma. Usually we are following Keynote 189. That means we use pembrolizumab and 4 cycles carbopemitrixid. Then we stop the carboplatin and continue pemetrexed and the pembrolizumab. So per year, almost the cost of the treatment is 400,000 riyals per patient. And when we compare it with the Nivo-AP, it is 560,000 riyals. So by use of Keynote 189, we can save 27% reduction in the cost of the treatment. And we know that the other way, when we use it for squamous cell carcinoma, the right side of the screen, you can see that we are using the Keynote 407, which usually 4 cycles combined chemo pembrolizumab. The cost will be around per patient per year around 373 riyals, Saudi riyals. Now, when compared with the Nivo-AP, based on the Checkmate 227 or Checkmate 9LA, we can see that the cost of the Nivo-AP is almost 560 riyals per year. So we are saving almost 33% by the use of Pembro chemo in comparison with the use of the Nivo-AP. Now, what the guideline telling us? Usually, we almost follow the NCCN guidelines, and we have to be careful when we read the guidelines. We have to know what is the meaning of the category 1 and category 2, and that mean because this will be reflected on our choice, that when we say category 1, that it is based upon high level of evidence and there is uniform consensus that the intervention is appropriate. While when we talk about 2A, this is inferior option. That means we have lower level of evidence, and despite that there is uniform NCCN consensus that the intervention is appropriate, but it is not the best option. Now, and we have to be careful also when we read the guidelines about the meaning of preferred versus other recommended. When we said preferred intervention, that means the intervention based on superior efficacy, safety, and evidence, and also affordability. While when it comes to the when they mention this is recommended, other recommended intervention, that this option or this drug is somewhat less efficacious and more toxic, or based on less mature data, or significantly less affordable for similar outcome. So let us apply this what we see in the in those patients with PDL1 lung adenocarcinoma with PDL1 more than 50%. This usually, as we mentioned, we look for the monotherapy in this group of patients. So what options we have? And we have to look first for the preferred group and category 1. Now, for the preferred category 1, we have Pembro, and we have also the combination of platinum plus pemetrexed. Pembro also is category 1. Atezo category 1 also. Also simipilimab is category 1. And so while the others are all in the adenocarcinoma are recommended but not the preferred option. So these are the preferred options. When it comes to the squamous, again, Pembro used on both sides, adeno and squamous, and we already discussed the trials that mean the 40024 that included both population. Now, other preferred options also Atezo, Simi, and while the other options are all just recommended, not preferred. Now, when it comes to those patients with less than 50%, then usually we use the combination here, the preferred option. Again, they put category 1 pembrolizumab-based therapy, that means Pembro with carbopemetrexed, as we saw in the keynote 189, or Simi as other option for this patient. The same option also used Pembro as category 1, but the combination here for squamous cell usually we combine with we use the backbone chemotherapy carbotaxol or carbopaclitaxel and or carboabraxane, and also simipilimab is another option as combination. So the combination for those patients with less than 50% of the PDL1. Now, this is the main options, and we'll go back to our patient. Now we remember this patient came with massive with pleural effusion and pericardial effusion, and she was non-smoker, NGS negative, PDL1 was low, 1%, and this patient started on keynote 189. And the patient almost now she completed 3 years, and she is maintaining the response. Despite that, she when we discontinued the treatment after 2.5 years, she showed some disease activity. So we started second course of pembrolizumab. The patient now almost is disease-free, and this is her last CT scan done 1 month ago. So that means it gives us clear message that revisiting the immune therapy is an option for those patients who progressed after discontinuation of the treatment. So we can conclude that pembrolizumab monotherapy provides superiority over chemotherapy. That usually we are worried that could immune therapy work alone? Yeah, it can work alone when we have PDL1 more than 50%. and it showed not only it worked well, but also showed superiority over chemotherapy in metastatic non-small cell lung cancer in terms of overall survival, progression-free survival, duration of response, both in for adeno and squamous. And for that, considered as the preferred option in the guidelines. Now, those patients who completed 35 cycles, that means 2 years of Pembro, experienced long-term overall survival. And the other message which I found in my patient, the second course Pembro at the time of disease progression was visible and associated with the anti-tumor activity. And thank you. Shukran. Back to you, Aisha.
Thank you so much, Dr. Ahmed, for this insightful and comprehensive presentation. So, dear doctors, please feel free to, if you have any question, feel free to open your mic or write it in the chat box.
Thank you.
So, Dr. Ahmed, I have one question.
Yes.
Could we revisit Pembro after completion of the first course if a progression happened?
Yeah, now we have clear answer. This was an important part of the follow-up, 5 years follow-up for all the keynote trials using pembrolizumab in lung cancer. And that was question, can we revisit immune therapy after immune therapy? The answer now is clear. Yes, we can. And we saw the response. And the best responders for the second course, those who who achieved initially excellent response, and they maintain the response. So that means the response is there, and it is not only response, overall survival, and the response rate reaching up to 50%. So yes, it is, and this reassuring for us, because some patients sometimes they refuse to stop the treatment because they don't face side effect, but only the financial toxicity, which is they don't feel of it. So they, please, doctor, don't stop the treatment. Can you guarantee us that the drug, the disease will not flare up? Now with this data, reassuring them that no problem, don't worry. Even if the disease recurred, we can resume it, the treatment safely. And this is what happened with my patient, which I showed to you. That almost I revisited the treatment and without any problems. And by the way, the good thing also about immune therapy for those colleagues who are not working in oncology and not familiar with it, that even with you can make some longer spacing. That means I have one patient coming from far place, from outside the kingdom. Sometimes she is not coming for every 6 weeks for her treatment. Even with longer duration of interval between the cycles, the treatment is durable. The effect is durable. The treatment effect is durable.
Thank you, Dr. Ahmed. So there's another question. What's your recommendation in the brain mets, IO or IO chemo or single IO?
We know that we cannot depend on the immune therapy for the treatment of the brain metastasis, and those patients included in the brain mets, patient with treated already, that means inactive brain mets after treatment. So this is the difference between chemotherapy, between immune therapy in general, and the targeted therapy. Look to the, for example, those patients with ALK mutation. Now, CROWN trial, it showed, amazing results. You can treat only with targeted therapy the brain mets. You don't need, in many cases, to use the radiation or sometimes surgery. So this is the difference. Now we cannot depend. We have to treat for those patients because maybe the penetration is not there. Despite that, some data about immune therapy that it showed it can work immuno in brain mets in some way, but should be inactive brain mets to consider. But generally for immune therapy, it is not we should not depend on it for treatment of brain mets like what we do in the targeted therapy. Deal with the brain mets in the classical way, and continue your treatment for the systemic disease.
So there's another question. What's your recommendation in the PD-L1 negative? Chemo, IO, or IO?
The answer is clear. Now the benefit is there for all the comers. We saw the benefit even in 1%, less than 1%. That means it is almost zero. So the patient with all the comers, they benefited, and the joint analysis designed mainly for those less than 1%, and we saw the benefit. Despite that, the benefit is of course lower than those patients with PD-L1 positive, but even with less than % we saw 10% 5 years progression-free survival over 10%, in comparison with 0.6 for the chemotherapy alone. So immune therapy should be given for all the comers without actionable mutation.
When you recommended IO in case of progression after finishing the adjuvant IO?
Usually we noted the answer, I think, indirectly came from the 5-year follow-up for the Keynote trials, that after immune working. So revisiting, we can apply the same principle. Revisiting the immune therapy is an option. So despite that, some experts talking about 5-6 months duration of disease-free interval to consider the immune after immune, if there is like what we do in the say renal cell carcinoma, pembrolizumab, progressed 6 months. No, we don't have clear answer, but we have indirect extrapolation information coming from the 5 years follow-up of the Keynote trial, that yes, we can revisit, and we can reintroduce, so we can consider a second course. So I think we don't prefer to burn our lines. So revisit the treatment, see what could happen, and unless if the disease is looks like progressing grossly, and you can see that the interval less than 6 months with aggressive disease, that with complete adherence, fully adherence of the patient to the treatment, then you may consider use of chemotherapy as an option.
Can we use the pembro in PD-L1 negative?
This is what we said. PD-L1 negative, we can use it, but we cannot use it alone. This is the point, the difference, that we have to use it with chemotherapy. And why we insisting for the use of immune therapy? Because the immune therapy will open the window for the patient for good quality of life without chemotherapy. For how long you can continue chemotherapy? Now, usually the patient, after few cycles, they start develop pancytopenia, and they cannot continue with. While if you start immune therapy, you can then drop, especially for those with squamous, after 4 cycles, no more chemotherapy, only pembro alone. So you can maintain them with good tolerability. The only thing that you have to do is to follow the thyroid function. This is what we do in our practice. So the patient coming every 6 weeks to us, the squamous patient, every 6 weeks, we do every 3 months thyroid function. And usually they enjoy good quality of life. We don't need to do labs. We don't bring the patient 1 day before. And this is and not only this, good quality of life, but also we have benefit, as we showed in the joint analysis of Keynote 407 and 189.
Thank you, Dr. Ahmed. And there's another question in your practice: how to overcome a hyperprogression with the IO?
Yeah, usually we have to be cautious in interpretation of the hyperprogression. That mean just we have to differentiate between these cases of hyperprogression versus, I mean, because usually we need some time for the immunotherapy to start working. Usually what we do in those patients who progressed on or hyperprogressed on immunotherapy alone, usually we consider combination or adding of chemotherapy in addition. So, and this is included in the guidelines as a preferred option. When you see your patient is hyperprogressing on immune therapy alone, addition of chemotherapy might control the disease 4 cycles, then you can get rid of it. So by this way, you can bridge this period of hyperprogression and overcome it.
And there's another question: who are best patient to benefit from an IO?
As we mentioned, that those lucky patients with the higher the PD-L1 is the best response. Those who benefit or who completed almost 2 years of the treatment, those patients are the best. The lucky patient that they will benefit from the treatment even if we revisited. So the most important, prognostic factor we noted in addition to the PD-L1 positivity, the higher the PD-L1 positivity, the better the response. And those more than 50% of the PD-L1 by TPS score are the best responders. But in addition to that, those patients who completed 2 years and they did not progress, so we congratulate those patients. And usually we are reassuring them that even with the stopping of the treatment, 80% of you will enjoy 5-year survival without progression. So this is the most important factor.
So, if there's any question?
Maybe the chat box, some question. The chat box, yes.
Yes. Do we need VDL testing for all patients, or we can start with without test?
This is an important question. Now, after this data, many colleagues will say, why you do PD-L1 testing? You showed us the benefit for all the comers. So what is the purpose of the test? The purpose of the test mainly for the consideration of monotherapy. Some patient may choose, please, doctor, I don't want chemotherapy. So they have the right, and we saw the benefit is there. It is not only, it was amazing benefit. So why we are doing it, to see the score. If it is more than 50%, then we can, choose the 0.24 trial monotherapy pembrolizumab alone can treat this patient. So this is the only purpose. And it is important for many patients they will be they like to receive only pembro alone, and the benefit is really amazing. Despite that, we as oncologists, we trust only our chemotherapy, but we with this 5 years follow-up, we change our mind that we are facing, some new era of immune therapy for those lucky patients. And I have one patient, colon cancer. We gave her all types of chemotherapy. Then the result of MSI came high. Now she's enjoying chemo-free treatment with pembro alone. So don't worry. If your patient strong positive PD-L1 more than 50%, put him on pembro alone and trust the treatment. It will work nicely.
So here's another question. If the disease progresses after completing complementary immunotherapy, what strategies are available to control this progression? And is there new research supporting the effectiveness of combining immunotherapy and endothelial growth factor VEGF inhibitor in such case?
We have the trial of Power 150. We know that it used, but this trial, it is by using of bevacizumab. This is usually we practice it even in the first line setting. But I think atezo-based Empower 150 trial born dead because we did not add much to the benefit. Now, for this patient who progressed on adjuvant, again, the revisit strategy is there and will depend on the disease-free interval. When it is less than 6 months, we have to consider the using of chemotherapy plus either chemotherapy alone, chemotherapy with bevacizumab. But again, we should not rush to these options. I think still there is window for revisiting the pembrolizumab. We should, unless if there is, hyperprogression or high burden disease. I think revisiting at this point, if the progression is mild progression, the disease burden is low, so we can use immunotherapy alone. If the disease burden high, we may use the combination. And also we should consider the baseline PD-L1 positivity. If it is more than 50%, then immunotherapy might be an option alone, monotherapy. If it is the PD-L1 more less than 50%, the combination should be there. So usually we upgrade and again, the most important is the disease burden and the durability, the disease-free interval 6 months or less.
Thank you, Dr. Ahmed. Is there any more question? So I think we can conclude. Thank you so much, Dr. Ahmed, for your insights and for your excellent presentation. And thank you all for attending, and have a great night.
Thank you very much. شكرا جزيلا. نشوفكم على خير إن شاء الله. شكرا للزملاء الحضور. ألف شكر. شكرا جزيلا.